How's it going, guys? We have a medium difficulty question, hepatobiliary 2CK3. If you're studying for step 1, you got to ace 2CK eventually. We've got a 46-year-old woman who has a background of cholelithiasis, stones in the gallbladder, as evidenced by her episodic abdominal pain, which is our biliary colic. Fat 40s, female, fertile. She's going to have cholesterol stones, high estrogen levels, upregulate HMG-CoA reductase, increase cholesterol secretion into bile. The fertility aspect, history of pregnancy. Progesterone can cause biliary sludging due to decreased biliary peristalsis. Now, in this case, we've got high amylase. I've seen USMLE omit lipase. They'll just give you a high number for amylase. You say, well, I don't know the normal range. You don't need to. It clearly is a high number there. And then you should know your normal ranges for bilirubin and ALP. Bilirubin should be 1.0 grams per deciliter. And USMLE doesn't have to specify that it's increased direct. You can infer that we have an obstructive jaundice here. And alkaline phosphatase should be 150 to 150. Okay, and clearly we're above 150 here. So what's the next best step in diagnosis? Choice A, CT the abdomen, correct answer. Now, this is what has happened. In the setting of cholelithiasis, stones in the gallbladder, one of those stones will descend into the biliary tree. We now call that choledocholithiasis. Now, depending on the stone location, if it's higher up in the biliary tree in the common bile duct where it does not obstruct the pancreatic duct entering the common bile duct, we'll have an obstructive jaundice with a high ALP, high direct bilirubin, but the pancreatic enzymes will not be elevated. And that's simply choledocholithiasis is the answer, where we do ultrasound first, followed by ERCP. Okay, which is not the sequence here. We also have to think about head of pancreas adenocarcinoma obstructing the common bile duct. It's called Courvoisier sign, where you get a painless palpable gallbladder in a jaundiced patient who's afebrile. It's a lengthy seminar, okay? If you get, obviously, weight loss, B symptoms, smoker, it's more of pancreatic adenocarcinoma vignette. If they tell you there's a remote history of cholecystectomy, 24 years ago, a patient had a removal of the gallbladder, then it's not going to be a stone, it's pancreatic adenocarcinoma. If they tell you the gallbladder was taken out a month ago and intraoperative cholangiography was not performed, the implication is that you have a retained stone within the cystic duct that's now descended and blocked the common bile duct, and so that's choledocholithiasis with that vignette. Now, in this case, because we have gallstone pancreatitis, the sequence USMLE wants is ultrasound first, then CT to diagnose the degree of fluid collection within the pancreas or pancreatitis, followed by ERCP, which is further diagnostic and also therapeutic. Okay, it can remove the stone. But if you have the gallstone pancreatitis, you have to insert that CT scan between the ultrasound and the ERCP for USMLE. It's what they want, okay? And I have never seen MRCP as a correct answer in USMLE. I've only seen it as a wrong answer. Students choose it because it sounds weird. Theoretically, you can view the common bile duct well. There's no reason you can't do an MRCP, but it's not what USMLE wants. If an NBME 16 for 2CK comes out and MRCP is an answer, great, then I'll be educated at that point as to what NBME wants for updated stuff, but I haven't seen evidence of it yet. I'm not talking about Qbank nonsense. I'm talking about NBME forms. Now, a point to make is that normal saline is actually what we'd want to do next in this patient, but we're asking for the next best step in diagnosis, which is why saline's wrong. So if you have pancreatitis, you're going to do a triad of number 1, NPO, which means nothing by mouth, aka bowel rest. USMLE can write all 3 of those. It's the same thing. Number 2, IV saline. Number 3, nasogastric decompression. Okay, you want to decrease the GI contents to relax the pancreas, to remove any impetus for there to be pancreatic enzyme secretion. So we would do saline next in this patient, but saline, nothing by mouth, NG2, but we're not asking for that. We're asking for diagnosis. So we do ultrasound first, already performed, CT because we have gallstone pancreatitis, and then we're going to do ERCP. If this were not gallstone pancreatitis, it's just regular choledocholithiasis where the stone has not blocked the hepatopancreatic ampulla, we said ultrasound and then straight to ERCP. We're not going to do the CT scan. Endoscopic ultrasound, similar to MRCP, I have not seen as a correct answer in USMLE, only as a wrong answer. theoretically, that can be a way to diagnose pancreatic cancer when a CT is negative, but it's strongly suspected. Okay? Now, we could go on different tangents, but you could also be aware that cholangiocarcinoma, which is bile duct cancer, is the answer on USMLE. If you get a vignette that sounds like pancreatic cancer, where you have high direct bilirubin, high ALP, normal pancreatic enzymes for pancreatic cancer, and you do a CT scan, that's how you diagnose pancreatic cancer, but it's negative, you can go on to do an ERCP to diagnose cholangiocarcinoma in a patient who's a smoker in particular. Okay, you can also get clonorchis sinensis, more nonsense. That's a trematode or a fluke that can theoretically cause cholangiocarcinoma. MRCP, wrong fucking answer.